Hi, my name is Vicki Noble, and I'm the Vice Chair and Program Director for the Department of Emergency Medicine here at UHCMC. And I'm going to talk to you a little bit today about some of the point-of-care ultrasound findings in COVID patients to help with our management of these patients as we take care of them either on the floors or the ICU or the emergency department. There is a separate video demonstrating how to perform the lung ultrasound, so this will be more of a review of the findings and the clinical decision making around the point-of-care ultrasound findings. So this was kind of the first article out of the gate that was from a group that was taking care of patients in Wuhan, China. And they were describing, they had been doing lung ultrasound and correlating the findings they were seeing on lung ultrasound with lung CT. And this is helpful because I think one of the things that lung ultrasound has such a powerful potential in is replacing CT for some of the monitoring functions that we use in the hospital. So what they saw on lung ultrasound was a thickened pleural line. We'll go over these findings in a minute. They also saw some subpleural consolidations, and they also saw that pleural effusions were rare. And when they compared that to the CT findings, they saw that a lot of these findings were mirrored in the way that the CT appeared as well. Now, I will say, I do think a lot of these findings are not specific to COVID in particular. So these are the same type of lung ultrasound findings as well as CT findings that we see in all different kinds of viral pneumonias, including bronchiolitis in children. And so I don't think that these findings are very specific for COVID. Although when you have a test that diagnoses a patient with COVID, you can use these findings to show whether a patient is getting better or worse. And I'll demonstrate that to you in a minute. But I do think that the lung ultrasound is very sensitive. So when these findings are absent, the chance that you have a pneumonia due to COVID is very low. So just so that we're all on the same page, there are a few terms that we use in lung ultrasound, and I just want to make sure that everybody understands them. So the first term is what we call an A-line, and an A-line is indicative of an air-filled lung. And the reason for that is when the sound comes out of the probe and it hits the pleural line, behind the pleura there is air. And so that doesn't transmit sound, and so instead of having the sound go distal to the pleura, all it does is bounce back and forth between the probe and the pleural line. And what that does is that creates a series of horizontal lines that are refraction or reflection artifacts because the air in the lung is not transmitting the sound. And so these horizontal reflections are called A-lines. As the lung starts to fill with air, the sound is now conducted through the lung tissue because the water or the pus or the inflammation or the whatever the density of that tissue is now conducive to transmitting the sound waves. And so instead of having horizontal lines on your ultrasound, you'll have vertical lines that are a marker showing that the lung is full of fluid. And the interesting thing, and this has been proven in many different studies, is that the more B lines you have on the ultrasound, the sicker the lung and the more dense the lung tissue is as it is filled with water. So a lot of times this seems, when I describe this to people, I can see like a quizzical look on their face. But I think this picture here makes it quite simple. And it really is this simple. If you have horizontal lines like in the square on the upper right of the slide, those are the A lines, and that means that the lung is air-filled. There's no fluid in the lung. Whereas if you have vertical lines, like in the lower square on the slide, the lung is now starting to fill with fluid, and those are what B lines look like. Now, one of the other benefits of lung ultrasound, in addition to being portable, is that you can use it as a monitor because the dynamic artifacts of A lines, B lines, and some of the other artifacts I'll discuss in a minute change in real time. So this patient is a patient with acute decompensated heart failure. The 8 zones on the left side of the screen, you can see lots of B lines and lots of fluid in the lungs. And the 8 zones on the right side of the screen are the same patient, but after 15 minutes of PEEP. And the reason that is so important is because that means you can use the lung ultrasound as you change the physiology of the patient, either with ventilator settings or with medications or with interventions on positioning. and then check to see how your interventions are impacting the lung physiology. And so that's one of the things I think that's so important about lung ultrasound is it's a really real-time dynamic monitor. And at the end of this discussion, I'll give you some resources where you can go online and teach yourself a little bit more about that. Okay, so I don't know if any of you have been following on Twitter, but there is a physician, Dr. Chen, who is an emergency physician in Madrid, Spain. He's a good friend of mine. And about 3 weeks ago, he was diagnosed with COVID virus. And he monitored himself at home during his quarantine with lung ultrasound and posted those images on Twitter so we could learn from his anatomy and physiology as he battled the disease. He's doing well, he's improving, but I'm going to share, with his permission, some of his ultrasound findings, and I think it provides a really valuable teaching tool. So this is day 1 of his disease. You can see here, this is the pleural line, and you can see the rib shadow here. This is the interface of the chest lung cavity, and here's below the diaphragm with the liver tissue there. And as you can see, the pleural line is very thin and crisp. There are some horizontal reflections and refractions down here, but there aren't a lot of irregularities of the pleural line or B lines. And so this is essentially a normal lung ultrasound. This is day 4, and you can already see on day 4 that the pleural line has become much more irregular. There are B lines now that are scattered in this field of view. There is some peri-lung fluid here separating the visceral and parietal pleura, so a small little effusion there. But I think you could appreciate, even if you don't know a lot about lung ultrasound, that this lung doesn't look quite as happy. And all the infection is now causing these irregularities, these vertical B-line refractions, and some of the subpleural consolidations that you see right here. This is day 8, and you can see now the B-lines are starting to become confluent. So as I said, the more B-lines you have, the sicker your lungs are. They've correlated that with CT, with densitometry, with wedge pressures. And so you can see that some of his B-lines are now starting to become confluent. He does have some spared areas, and that's really important, especially in viral pneumonia and also in ARDS, is you'll have areas of normal lung right next to areas of very diseased lung. But mostly, I think in this one, you can see the confluent B-lines. You can also appreciate there's a small amount of fluid right here separating the visceral and parietal pleura. But again, these are clinically very minimal pleural effusions. This is day 8, but in the posterior zones. Again, you can see some more of these B-lines. You're starting to notice that the pleural line is a little more bumpy and thick as it becomes inflamed. And again, having some area of normal lung right next to some area of diseased lung is very classic for both viral pneumonia and, in extreme cases, ARDS. And then on day 14, you can see now he has a bunch more B-lines, but his pleural line is really almost, it's become quite thick, and it almost looks like maybe a half a centimeter or so here, as opposed to the thin, crisp pleural line on day 1. You can see some more B-lines, but they're a little less confluent perhaps on this day. And again, you can see kind of the subpleural fluid and irregularities of that pleural line. And then I think this was actually just today. This is his lung on day 16. You can see the B-lines are starting to space out, so they're becoming a little less confluent. The pleural line lags behind the rest of it. It's still quite irregular and thick, but we don't see the big divots or moth-eaten pattern that we saw on earlier days of this. And again, just to kind of clarify this, because sometimes it can be hard in the abstract, what we see here are 2 pictures side by side. Both patients have B-lines, so both patients have lots of fluid in their lungs. But the patient on the left, you can see these very moth-eaten appearance to the pleura. It's thick, it's irregular, while the patient on the right has a very thin, crisp pleural line. And we use this to help us distinguish between inflammation and hydrostatic pressure causes of B-lines. So for example, in pneumonia, especially viral pneumonia, you'll see a lot of these irregular pleural lines, sticky, bumpy, subpleural consolidation type appearance to the pleural line. Whereas in acute decompensated heart failure, it's a hydrostatic pressure problem. And so the pleural line often remains thin and crisp and pretty regular. So the reason I put that up there was just to kind of go through some of the findings on the lung ultrasound, and also to kind of delineate what the different technical terms are for you in pictures. However, I do think there's two other things that are quite useful, especially for screening in the emergency department when you have a sick COVID or viral pneumonia patient. One is to look at the IVC, and for those of you who are critical care or emergency trained out there, there's a lot of controversy about using the IVC ultrasound as a proxy for fluid status. However, I believe that at time 0, when you come to the emergency department and you have not started any resuscitation, it can give you a clue as to what's going on with the heart and the fluid status overall. So if you have a very thick, plump IVC with minimal respiratory variation as the patient is spontaneously breathing, you worry that the pressures in the venous system are already elevated, the heart is failing, and I'll show you how we look at that in a minute, and so that you may want to restrict your fluid. Whereas if you look down here, you see that the IVC has a lot of respiratory variation. It's more thin, not quite as plump. And while, again, in respiratory failure, you want to minimize your fluid resuscitation, this patient is probably more fluid tolerant, whereas this patient, I may think about going to pressors much earlier. The other thing I think we can do in the emergency department for the upstairs people is look at the heart, because like many kinds of viral pneumonia, there is a subgroup of patients in COVID that goes on to cardiomyopathy. This can even be after in a kind of later stage of the disease as the lungs are starting to heal. And so if we have a baseline echo that we can perform in the emergency department showing either globally okay function versus globally not okay function, I think that can help for the upstairs teams as they're managing these patients when things change. If they can look back at the emergency echo and say, oh, at time 0, the patient had a good EF, and now it's much decreased, that can push the clinicians upstairs to think of other interventions. And like I said, this is a quick overview, but there are so many great online resources, and one that this is free. I don't get paid by them or anything, but this is, I think, the best site for point-of-care ultrasound learning because it's very discrete, small videos. It shows lots of great graphics. And it's a well-organized site. You can go on here to learn about more lung ultrasound, sort of advanced things like vent management, IVC ultrasound, and more cardiac ultrasound on this site. So what I would propose in our current state as we're thinking about this is I do think that lung ultrasound is not specific enough. As you saw, my friend Dr. Tung in Madrid had pretty diffuse findings on his lung ultrasound, but he was managed at home and his O2 saturations at home never dipped below 97%. So I think we can use lung ultrasound as a monitor, but I think we have to use our triage initially based on oxygenation. So if you're symptomatic or we have a suspicion for a COVID patient, if you have normal oxygenation, we may do POCUS just sort of as a baseline, either to reassure you because all we see is A lines. You may still have the virus, but your lungs are not sick, and you can go home with monitoring. And I even would postulate that in these patients with normal oxygenation, even if we see B lines or subpleural consolidation like we did with Dr. Tung, you can still go home with monitoring because as he has demonstrated, you can do that, especially if we have ways to monitor patients' home oxygenation levels. For our symptomatic patients who are hypoxic, I think lung ultrasound, especially at time 0, doesn't help much in terms of management, but I think by getting a baseline echo, a baseline IVC, and a baseline lung assessment with ultrasound for the upstairs teams and having a baseline CT to correlate that with, we could maybe prevent some of the repeat imaging that needs to be done when patients change in status happens upstairs. So if their oxygenation worsens or they develop arrhythmias, I think those baseline lung ultrasounds could save us from having to transport patients to different radiology tests all over the hospital, and we could perform bedside POCUS, which may decrease infection control issues. So in summary, those are some of the outlines and ideas and sort of crowdsourced thinking on point-of-care ultrasound in the COVID virus era. There are lots and lots of online resources, core ultrasound being one of them. If you are interested, please email me. Again, my name is Vicki Noble, and I can help point you to other resources for this.
Now is the time. Now is the time for all